now I would like to introduce Dr. Christopher Tignanelli, who is Assistant Professor in the Division of Critical Care and Acute Care Surgery in the Department of Surgery. Dr. Tignanelli, excuse me, you are muted.
I just realized that. Thank you very much for inviting me to talk today. I'm very excited to talk about our research that we've done in COVID-19. I'm a co-director of a research group called the Minnesota Critical Care Outcomes Research Effort. And that's a research group of about 30 or so researchers in surgical, anesthesia, and medicine critical care at the University of Minnesota. And it includes researchers in Wisconsin, North Carolina, Texas, and some other locations. And the research that we do kind of covers the gamut of clinical research. So one thought with putting this presentation together is, how do I sort of tie all of these clinical trials and artificial intelligence and such together? So we've done all that sort of using the learning health system, and I'll kind of walk through this. So we know that it takes about 17 years for about 14% of original research to actually get to benefiting patients. And in 2009, Barack Obama said, we have the best medical schools, the most sophisticated labs, and the most advanced training of any nation on the globe, yet we're not doing a very good job harnessing our collective knowledge and experience on behalf of better medicine. Less than 1% of our healthcare spending goes to examining what treatments are most effective. And even when this information finds its way into journals, it can take up to 17 years to find its way into an exam room or an operating table. Well, we don't really have 17 years for COVID. We only had months. So I'm going to talk about how our research group and our institution, mHealth Fairview, which includes the University of Minnesota, adapted to this challenge to rapidly develop new knowledge through clinical trials or artificial intelligence. And then also, how do we translate that right into our system and then evaluate its impact in real time on patient outcomes? And that's what I'll be talking about today. So we use the Learning Health Systems framework. So Learning Health System says essentially 4 key elements. The first one really starts with the critical appraisal of the external evidence. And that's really where the living literature review comes into play. So we actually developed a team which numbered close to 100 researchers across the entire medical school. And that included medical librarians, pharmacists, MDs, PhDs, to review all the evidence that we could on various hypothesized therapeutics for COVID. And we went as far back as the original SARS epidemic to try to identify, this was back in February, to try to identify what medications may be efficacious in our current pandemic. Additionally, in addition to just looking at sort of what we know from literature review, we need some way of harnessing our local data so that we can identify for our patients, even if we identify that, let's say remdesivir, that's now a bad example, but steroids, for example, let's say steroids are beneficial in COVID. How many of our patients are actually getting COVID? How compliant are we with these new guidelines, especially when evidence is rapidly changing? And then what can we do to sort of improve patients getting these treatments as they sort of come up and be shown as efficacious? And then once we identify, once we harness that data, how do we actually implement it in our system? And then of course, evaluate it. And then this process repeats itself. So once we kind of repeat a cycle, we publish our results and kind of keep going on around the cycle. Okay, we call that the learning health system. So first thing is that living literature review. So we built the COVID evidence-based medicine team back in late March, early April. And the MinCore group I co-direct, we were actually building our own webpage. And on that webpage, we had links to various therapeutics, and we summarized the literature for them. So this is the leadership of our EBM group here. This is the webpage at the top. And this is what the webpage looks like. And there's these various evidence-based reviews. We did about 26 of them or so. And they get updated frequently. And what they look like, this is the review for remdesivir. This is about a month or two old. So we had to create sort of the new hierarchy of evidence. So we analyzed all the SARS-CoV data, for example, and we summarize all that data for on remdesivir, in vivo data that we had on other strains of SARS-CoV or MERS-CoV, and then also observational data, randomized control data, and this gets updated in real time. And again, as I mentioned, we've done this for multiple different medications. So that's how we kept an eye on sort of the literature. And that's ultimately one of the key things that led to us launching these low-Sartan clinical trials. And we're actually about to launch a trial of metformin, and I'll talk about that in a little bit. We also need access to our local data. So we didn't have an infrastructure to analyze our local data in real time, so we kind of had to build that. Most of the infrastructure we have is actually on the medical school side of things, but we needed something that was closer to the electronic health record. So within mHealth Fairview, we had researchers from Institute for Health Informatics, various departments, the School of Public Health and Computer Science, and we built a large infrastructure that includes Windows machines, Linux machines, a GPU server for artificial intelligence, and a cloud computing platform that allows us to take any knowledge that we sort of gain through this process and rapidly integrate it within Epic. And that was, of course, done in partnership with Epic. This is really led by our Chief Analytics and Care Innovation Officer, Genevieve Melton-Mutes, and Eric Murray, our Director of Information Technology and Data Solutions. So what do we do? So every day, all of our Epic data essentially dumps to us in raw form. And a team of us, myself being on that team, pre-processed all that data, all the structured data elements. But we also wanted to get other data that was in unstructured notes. So we use something called natural language processing, which is a branch of artificial intelligence. It's essentially what powers your Alexa or Google Home, for example. And that can read through these unstructured notes, ED provider notes, operative notes, whatever, and pull out different data elements and essentially create them into structured data elements that could then be studied. So we wanted to pull in signs and symptoms that patients were presenting to our emergency department with. So we use natural language processing to pull that. And essentially we put all this together, and every day we create a COVID quality and a research database. So essentially we fed in all the medicines a patient got, all their vitals, all their home meds, diagnoses, everything, and we created this clean database afterwards. At the end of the day, you get this output of these sort of clean databases. And this is what our data mart contains. So it contains structured data, comorbidity, socioeconomic data, population health data, cytokine assays, tag echoes, etc. Bioassay data from our clinical trials, images, and unstructured natural language processing data. So I'm going to talk about each one. So first, the structured data. So we have 200 plus home medications that patients have taken, all their comorbidities, every lab a patient has, and these are all clean variables. We're also tracking 40 hospital complications in real time. And then we have a lot of other data. We're tracking, for example, tocilizumab, remdesivir, et cetera. And then we have a lot of other socioeconomic and demographic data as well in our patients. For bioassays, so I'm going to talk about our clinical trials here, because I think that's where that sort of fits in with this database. So as I mentioned, we did this large living evidence review. And one of the ones that we did was on the ARBs. So SARS-CoV-2 works just like SARS-CoV-1, which was the epidemic back in 2004, 2005, in which it enters through ACE2. And it actually caused downregulation of ACE2. ACE2 is actually protective. And what happens, or what's hypothesized to happen, is when you lose ACE2, you get unopposed stimulation through angiotensin 2. And angiotensin 2 drives AT1R, which causes lung injury. And by having more ACE2, that actually drives AT2R, which is lung protective. So it was hypothesized that if this is a harmful pathway, you could potentially treat with an ARB and block at this AT1R and improve outcomes in the original SARS epidemic. And Kuba et al., in a paper published in Nature Medicine, did an in vivo mouse model evaluating this hypothesis and saw the mice treated with an angiotensin 1 inhibitor, that's sort of the blue here, versus vehicle or placebo, they call it vehicle in vivo models, that's the green here. Angiotensin 1 receptor treated mice had reduced lung injury and reduced pulmonary edema. So we published back in, this is around early April, late March, a review in Lancet Respiratory Therapy offering the same hypothesis in COVID-19, that inhibition of angiotensin 1 receptor might improve outcomes in SARS-CoV-2. And then we published another review, sort of going more in depth. And again, this is the benefit of our living review. Right? We had already evaluated all of these pathways. We were able to kind of put everything together and sort of give hints at what secondary or combination therapy might look like. So for example, we put this out hypothesizing JAK inhibitors might be beneficial. This was pre-JAK inhibition being added to that remdesivir in the ACT trial. So we hypothesized that ARBs would be beneficial. Very recently, a preliminary pilot study came out, a randomized trial looking at another ARB, which saw lower CRP and shorter time to discharge for patients treated with telmisartan. And they saw about a 50% reduction in mortality. And that was only 78 patients. It was obviously not powered for this outcome, mortality. The p-value thus was not significant. But preliminary looks interesting. So we launched 2 randomized controlled trials back in April. So we have an inpatient trial and an outpatient trial. So for our inpatient trial, we're looking at all adults with laboratory confirmed COVID-19 and respiratory SOFA of 1+. And this is a multi-site trial. So it's at mHealth Fairview, Hennepin County, North Memorial, and then a lot of other sites across our country. These are inclusion criteria. These are the exclusion criteria. Most of them are related to losartan. We've received funded from the Bill and Melinda Gates Foundation and the Minnesota Partnership for Biotech and Medical Genomics for our inpatient and our outpatient trials, respectively. Our intervention is losartan, 50 milligrams twice a day. We picked this dose because it achieves approximately 99% inhibition of AT1R versus matched placebo. Our primary outcome is estimated P-to-F ratio, PEEP adjusted. They have a host of secondary endpoints, mortality, stuff like that, for example. For our outpatient trial, our primary endpoint is the need for hospitalization. And we're collecting a host of bioassays. And one of the benefits is that this can then be linked back to our database. So on day 1 or baseline, we're collecting EDTA tubes from patients, and this allows us to extract plasma, which we've sent to the NIH in late July. We should be getting the results in about 11 days. But that was sent for proteomics and a whole host of other analysis. We also isolated PBMCs, so they're doing sort of single cell B and T cell, RNA-seq, and other sort of analyses. Sodium citrate tubes, so we can look at the coagulation pathway. We're also collecting tubes of angio inhibitors, so we can look at the RAS pathway. We're collecting serum, we look at antibodies and metabolomics. And again, this is at multiple time points for COVID. We're collecting whole blood. We're doing epigenetics to look at epigenetic or DNA methylation modifications on ACE2, for example. We're looking at genetic age in collaboration with Yale, and if that's a predictor, genetic age has been shown to be a predictor of worse outcomes for West Nile virus. We're also collecting nasal or oral pharyngeal swab samples at various time points. We can look at viral load. And for some of these, for our outpatient trial, we're actually collecting samples all the way out to 5 to 7 months on patients. So that's how we, that's kind of what's going on with the losartan trial. So we're about 75% enrolled. We've done our first interim analysis in the losartan trials, and we should have results in about a month or so. Our trials were not stopped due to futility, so we know that at least so far we can say that we didn't see futile results with losartan, and we'll see what the results look like hopefully in about a month or so. We were really interested in March, late February, early April in trying to predict which agents may be beneficial. And that's how sort of our interest on the ARBs began. And we collaborated with a computational biology lab here, David Odie's lab, which is NIH funded, to potentially look at what agents might have inhibition of the viral life cycle. We released this paper in April on BioRx. And essentially what this shows is this is the viral life cycle. So there's viral entry. These are various steps in the viral life cycle. There's transcription, translation, viral assembly, and viral release. And what you're seeing here is this is the time to produce 1,000 viral copies. So if you see black here, for example, that means that this step did not complete. If you knock this step out, that the viral life cycle didn't complete. And this is just essentially the strength of inhibition. And what we saw was, we saw that there's essentially three key areas where you can inhibit the viral life cycle. So those drugs were hydroxychloroquine. So we hypothesized in early April that hydroxychloroquine would ultimately fail. mTOR metformin. So we hypothesized that mTOR metformin would be beneficial in COVID. And we used our local data also, and we saw significant improvement in mortality for patients treated with metformin in COVID. And that paper just got accepted to one of the Lancet journals last week, so it'll be coming out soon. We predicted that remdesivir would be beneficial in COVID, which is now, you have conflicting stories because the World Health Organization study did not see a benefit, nor did the China study, but the American studies did see a benefit. And then sigma-1 agonism, we have predicted that that would be beneficial. And recently, there was a paper published showing fluvoxamine, which is a sigma-1 agonist, had improvement in the need for hospitalization compared to placebo. So what they saw was patients received sigma-1 agonists at a 0% need for hospitalization versus, I think it was either 6 or 7% baseline need in the patients randomized to the non-fluvoxamine arm. So the other data that we include is unstructured data. So unstructured data is the natural language processing data. So our research group essentially developed an NLP construct to read through an emergency department note and extract signs and symptoms that a patient may have had so that we could use those to see what symptoms are most associated with worse outcomes in COVID, for example. How predictive is loss of smell or a cough or whatnot on long-term outcomes in COVID and short-term outcomes. So what we did was we took all of our clinical notes for COVID, and then we ran them through 4 different natural language processing machines. So Biomedicus, which we built at Minnesota, MetaMap, Clamp, and CTakes. And these machines essentially read the notes and make calls. So Biomedicus, for example, may pull this person had a cough. MetaMap may pull the no comment on cough. Clamp may pull this person didn't have a cough. And CTakes may pull this person did have a cough. And then we use what's called an ensembling method that essentially, you think of it kind of as merging the results of these different systems together, and then that sort of puts that data back into our data mart. So, for example, in the situation when 2 systems sort of made a vote that a person had a cough, and one, for example, said it didn't, those 2 systems that did see a cough would kind of win, and the ultimate vote would be that person did have a cough. And more methods can be found on our GitHub page. But essentially, this is what it looks like at the end of the day. So this is from our data mart. So each patient is a row, and these are different things called concepts. So there's a whole language of sort of structured or unstructured data in medicine, and all signs and symptoms are essentially mapped to these things called UMLS concepts. And these are various concepts here, but we could see these patients, for example, had abdominal pain. These patients didn't have any documentation whether there was or wasn't abdominal pain, and et cetera for other patients. When we presented this, there's an international conference on AI in medicine, and these results were presented at that conference in August. And interesting thing about this conference is for COVID, they picked 10 sort of research projects to be presented, and University of Minnesota had 2 presented at this conference. So that was kind of nice to see. And this was the other project that was presented at this conference, so longitudinal data analysis. So I've kind of talked about, we built structured data. We have bioassays from our various clinical trials going on. We have natural language processing, extracting unstructured data, and also images. So we have a large amount of images on patients. So we asked the question early on, we have images of patients who don't have COVID. We have images of patients who do have COVID. So we were wondering, can we develop an AI algorithm that could read x-rays and predict, does someone's x-ray look more like a COVID x-ray or a non-COVID x-ray? We also presented this at the same conference. And what we did was we trained it on, I think it was 47,000 x-rays of people that didn't have COVID. And this is pre our first COVID case, which was March 4th. And we trained it on for x-rays of patients that did have COVID from March 4th to July 1st. And then we prospectively validated this algorithm from July 1st through the end of July. So we fed it 7,000 x-rays for the month of July, and we knew if those patients are COVID positive or negative. and the algorithm spit out a score from 0 to 1.0. And you can see the purple ones were the ones that did have COVID. So when an algorithm said a patient's X-ray was a 0.7 or higher, the algorithm is usually right. It has specificity of 0.89 and a positive predictive value of 0.8. When the algorithm said an X-ray was 0.3 or below, essentially unlikely to have COVID, you see a bit of overlap. And one of the reasons the negative predictive value and sensitivity are so low is because a lot of COVID patients had normal X-rays. So we said, how can we use this to help guide clinical care potentially? And what we said was, let's real-time evaluate this end of the spectrum, because the algorithm looks like it performs very well over here. So we developed a real-time decision support system that went live on October 12th within mHealth Fairview, our 12 hospitals, to look at it, take any X-rays of patients that we know are not COVID positive and give the predicted probability that the patient does have COVID on this likely scale. So we do not offer any decision support to take an X-ray and say it doesn't have COVID. So two kind of different questions here. And I'll talk about how that all fits into a learning health system. So just to kind of summarize what we've done so far, we have an evidence-based medicine team that has reviewed the literature in COVID, and we use that to kind of predict what medicines might be beneficial in COVID. If we made a few predictions, some have been proven accurate, some haven't been tested yet, like metformin. We've developed a database which is supplemented by clinical trial data and structured and unstructured data and images. And then we've taken this data, and we've actually implemented some of these different findings into our system. So one thing that we did early on was we identified that from our literature review, patients that were on anticoagulation seemed to have better outcomes with COVID. So we developed a decision support system that would recommend anticoagulation to patients with COVID within our system, and then we tracked if that actually improved outcomes. And the other thing, as I mentioned, is we developed this AI system. We implemented that within Epic, and the goal of this is to evaluate how accurate is that system in real time, and ultimately we're undergoing FDA approval so that we can actually use this as an additional adjunct to diagnose patients with COVID-19. So I'm going to talk a little bit about our evaluation of these different systems.
Dr. Tignanelli, we had a question, and I just wanted to make sure that Dr. Lavalore's question was, I think you touched on it right on the end, but I'm going to allow her to talk and ask if she had any clarifying questions.
Yeah.
So, Dr. Lavalore, if you wanted to clarify, you are welcome to.
Yes, I'm particularly interested in how this can help clinicians in greater Minnesota or in rural areas.
You're talking about the AI system potentially?
Any system that you've talked about, this is all wonderful, but to the average clinician, a bit confusing.
Yeah, the downside of some of this, so let's talk about AI first, right? So if we develop an AI system to either diagnose something or predict something, we can launch it within our own system to deliver decision support. But if we want to sort of send it outside of our system, it has to go through FDA approval now. So before we can actually get this system, this AI system, for example, to an urgent care or critical access hospital or something like that, we have to go through probably another month or two of FDA approvals. But once that's done, this system's available in Epic. It's downloadable, so Epic has something called an app orchard. And this system is there. Right now, you can't download it because it's lacking FDA approval, but once we get it, you will be able to. And then if someone comes into your urgent care and gets an x-ray, maybe you're not thinking COVID, but maybe this system picks up, oh, this might be a COVID patient. That can then offer an additional element of decision support to, maybe I'll test this person. Same thing with the critical access hospital or smaller hospital that maybe you don't have the resources to get a rapid COVID test. Maybe it takes 6 hours or a day to turn it around. This could potentially give you another piece of the puzzle to identify patients that maybe you do want to put someone in isolation that maybe you think doesn't have COVID, but the algorithm predicts they do. The other way that I think it can help other hospitals is this is generating new knowledge. So for example, generated the new knowledge of anticoagulation, for example. And what I'll show, and I don't have to go through all the slides, but essentially what we showed is patients who received anticoagulation with COVID had significantly improved mortality, about 15% absolute reduction in mortality. So this allows us to kind of validate, we reviewed a bunch of literature early on, and Surbi Shah, our hematologist, worked with some national leaders to kind of make up anticoagulation protocol in COVID. I'll skip to it right here. This protocol, we kind of made it up, as did UNC and others. And what we did is then we evaluated, does it actually improve outcomes? And it did. So now we can take this knowledge, that's why I'm writing the paper right now. Other systems don't have to sit down and be like, oh, we have to build our own anticoagulation protocol. Here's one that we know works, for example. So you can implement that in your system. So I think these are just some of the different ways. The other thing is it generates knowledge to identify new candidates. So metformin, for example, was purely identified, and we just received funding to start that trial from sort of observational data analysis, seeing a strong signal for metformin. So if that trial ends up being beneficial, that could obviously then be used in rural areas or wherever.
And Dr. Tignanelli, we had a follow-up. Will you be able to use this system if you do not have access to Epic?
So great question. Right now, the cloud computing platform to deliver the system has only been built with Epic. So this is an issue that we have in informatics in healthcare. We have the issue of interoperability. So right now, the system that we have can only really work in Epic systems. If a Cerner system or VA system is interested, we are happy to share the algorithm with them, and then they could develop it within their EHR. But we do not have the capability to offer support to kind of build it for other systems. For anticoagulation, so we built a decision support system within Epic to essentially pop up and recommend to providers, hey, this patient's D-dimer is greater than 6. You should give them this dose, for example, of Lovenox. That was built only in Epic. So one of the things we're doing is we're collaborating with the AHRQ, the CDC, and something called the C19 Knowledge Accelerator, which is a COVID-19 work group, to build an interoperable decision support system for anticoagulation in COVID, the benefit of which is it would be agnostic to Epic. And we are working with partners at Cerner, VA, and other systems to potentially implement this across all EHRs. And this has been something we've been talking about doing for a couple of years in informatics in our realm. And COVID was kind of one of the main things that really forced us to kind of push this to let's just sit down and do this. Let's build this interoperable decision support system using something known as CPG on FHIR, which is clinical practice guidelines or computable practice guidelines on FHIR, which is an interoperable standard. So COVID is accelerating our efforts in the informatics realm significantly. But it's not perfect. So you're right. Right now, the AI system is really only available in Epic. So I can go through, this is what it looks like in Epic. So when the patients get the X-ray, it goes into the Epic's cloud computing platform. The AI algorithm is there and it can deliver CDS services. So what did we build it to look like? We built it we have a COVID-19 panel in Epic, and we actually have this X-ray detection flag in it, where it'll give you a percentage score, and then it has some information related to it. You also have the ability, you can add it as a column on your list when you print your list each morning. And the benefit of that is, the first patient I had that died from COVID was actually someone who came in who had appendicitis and picked up COVID in the hospital and then ultimately progressed to pass away. So if you have, and that person did have an X-ray. So if you have a patient, we're only getting baseline COVID tests on everyone they get admitted, but unless someone, over a week or 2 weeks in the hospital, unless they develop a fever, new loss of smell or something, we're not retesting patients. So, but we do frequently get X-rays. We get X-rays, especially in surgery, whenever we put NG tubes down, et cetera. So patients are getting X-rays rather frequently throughout their stay. So this potentially could pop up, your patient today looks like they may have developed COVID on their NG placement X-ray, for example. And then you can review and then decide if you actually want to get them PCR tested or not. So here's how mHealth Fairview is kind of doing with COVID. And this is last ran in August, so this needs to be updated, but this is our monthly mortality. So we ran about 15 to 23% mortality for all comers who got admitted with COVID. We launched a decision support system related to anticoagulation in May. One of our key questions was really, did this decision support system improve mortality? This is how we did for patients 65 and older. So we're now hovering at about 5% mortality for 65 and older. Our ICU admission rate, despite that, remains steady. We're about 40 to 50% ICU admission rate. An interesting thing, most of the people that have gone to the ICU do so within the first 48 hours of admission. Our readmission rate's about 5%, and that's holding steady still. One thing of note that I just put in all these slides because I thought it was interesting is that we're tracking non-English speakers and COVID-19, and we're seeing our rate of non-English speakers is rising. It's at about 40, I think it's about 45% right now of our admitted patients. So one thing that we do is this decision support system can track adherence with anticoagulation. So this updates daily, and where you can track each patient's adherence and also the provider's adherence with anticoagulation and the fuller's adherence, for example. And we're giving anticoagulation to about 80, 75% of our patients that get admitted. We have a cohorting hospital called Bethesda in St. Paul where we put all of our COVID patients. And we looked at adherence, and we really found that one thing that improved adherence in our best practices, and this isn't just for anticoagulation alone, was cohorting all of our COVID patients at a single hospital. So that's Bethesda. So patients that aren't at that hospital, only about 40, 50% of them are getting adherence with anticoagulation. And we published a paper about developing, we essentially took an LTAC and converted it into 90-bed COVID hospital. And then for ICU patients, adherence is a little better. It's about 60 to 80% or so. And again, at Bethesda hospitals, ICU adherence is 70 to 80%. And for non-Bethesda hospitals, we peaked in May when we launched this across our system, but then adherence sort of really dropped off as dissemination of the anticoagulation decision support system decreased. And then we look at adherence. So we look at adherence patients versus non-adherent patients. Both of them reduced mortality over time. But what was really interesting was when we looked at highest risk patients. So we looked at patients that had a D dimer greater than 6. What we see is that they're running 0% mortality if they got adherent anticoagulation versus patients who got non-adherent anticoagulation about a 40, 50% mortality. When we look at mechanically ventilated patients, we saw a similar trend, about 10, 20% mortality if they got adherent anticoagulation versus 25, 35% for non-adherent patients. And then we also looked at risk-adjusted analysis. So we adjusted for month, adherence, age, a whole host of things, remdesivir, tocilizumab, steroids, et cetera. And what we see is that the probability of in-hospital mortality, this is the red line here for adherent patients and blue line for non-adherent patients, mortality is decreasing over time. And that's because we're getting better with proning, we're getting better with LASIK. So all COVID patients get diuresed quite aggressively. We'll frequently diurese until the creatinine gets close to 2 to run them as dry as possible. So we're getting better with kind of ARD practices. But what we really saw was the patients that were adherent with anticoagulation had about this 15% absolute reduction in mortality. And that's similar to what Mount Sinai saw in their anticoagulation study as well. The odds of mortality are about 50% reduced. That's where the 15% absolute reduction came from. We recently reran these numbers about 3 days ago. That p-value is now down to 0.015, which is significant. We didn't see a huge signal for remdesivir, and potentially signals for tocilizumab and steroids. And then we look at any patients with a D dimer greater than 1. Again, it doesn't seem that anticoagulation matters for all comers. It's really these highest risk groups. So, this what I showed before was for mechanically ventilated patients. And then here, when you started looking at different D dimers, D dimer greater than 4, you start to see the separation. And then D dimer greater than 8, you start to see an even bigger separation. So there's certain populations that really benefit the most from anticoagulation. So I can just take a pause here. I've kind of covered a lot. I just wanted to kind of give an overview or survey of kind of the various research projects that are ongoing at University of Minnesota in COVID, and see if there's anything that the audience, you all are most interested in kind of talking about in any more detail. So I'll just stop right here because I see that we have about 13 minutes left.
Yeah, we did have one question. What are you doing to get this information out to the public? The alum comments that they've read almost nothing about it in the lay literature. So how are we getting this information out there?
Yeah, so we've engaged University of Minnesota's media department. We've published or put into preprint like 14 or 15 papers now, probably. I think half are in peer-reviewed acceptance, and then the other half are still in preprint and undergoing peer review. So that's one route of dissemination. The other route of dissemination, we do preprint, we do use social media to try to advertise. None of us have a huge amount of followers, so we just do the best that we can with tweeting out the preprints. And then for advertisement with the media office, we have done a few news articles. So we've had 2 papers on sort of the front page of the Star Tribune, or 2 articles. We've done a few TV interviews like Carol Levin and Fox 9. We actually interviewed with Wired magazine last week. So again, we're trying our best to kind of get this out. There's a lot I haven't shown. We have, I'll give you another side thing that's really interesting. We took zinc levels of every patient that got admitted to our hospital. We found out every single patient except for one was zinc deficient. And the level of zinc deficiency correlated with their oxygen requirements. And then we used our data to look at people on zinc supplementation. And actually the strongest predictor of reducing the need for hospitalization, even more than like meds, was actually zinc supplements. So I've now taken a zinc supplement every day since April. but yeah, I mean, we're doing the best we can to kind of get it out. But if you have any other ideas or know any other routes, please let me know. But we are working with University of Minnesota's media office.
Looks like we had another question in the chat. Dr. Wallen is wondering, what does adherent and non-adherent refer to?
Yeah, so adherent refers to, I'll scroll back to this, these boxes. So this is our anticoagulation protocol. It's very similar to UNC, Michigan's, and Wake Forest, because all 4 of us kind of worked together to build this. We have this lowest risk group, which is just your standard anticoagulation. So essentially any patient with a D-dimer less than 10 and no other risk factor should get this. So adherence is if they have these criteria and on admission, they get this, when either this Lovenox dosing based on BMI or heparin based on GFR, they would be considered adherent. If they got more than this, they're non-adherent. If they got less than this, they're non-adherent. Same thing with this box, D-dimer greater than 10 times upper limit of normal. And then ICU cancer, history of VTE. And then, of course, full anticoagulation for people with VTE, which is standard. So really all we really did was make up this middle box for COVID. That's how we defined adherent. And then there are other slides too. We looked at bleeding rate. I think patients that got non-adherent anticoagulation had like a 4% bleeding rate versus 1% who got adherent. And then VTE rate was 2.5% versus 1% for non-adherent versus adherent. So we did look at bleeding too, because I think that what's happening, a lot of patients are actually getting over anticoagulated, and that might be why the bleeding rate is so much higher.
And we had another question. What is the most appropriate dose for zinc supplementation?
No clue. I'm just taking the standard, I think it's 50 milligrams, I want to say. Don't quote me on that, but I'm just taking the standard one. But when we looked at it, we didn't look at the dose of zinc supplementation they were on. We do have that data. We just looked at patients that were receiving physician-prescribed zinc supplementation 3 months prior to their COVID diagnosis versus those who were not. And this is a risk-adjusted analysis. So that was all that we looked at. It's difficult to kind of adjust for everything, including for doses too. So that is something we could look at in the future. But I see another question about the anticoagulation guidelines. So we're actually working for anticoagulation. University of Minnesota is potentially the lead nationally on it, and that's how we've been working with the CDC and others. We are working with ASH, which is the hematology organization. So we engaged them probably back in May regarding our anticoagulation guidelines. So I don't think they've formally adopted ours, but we have been kind of working with them. One of the goals when developing, so the next level of decision support will be an interoperable decision support. So again, you could download it into your system, and that one won't matter if you're on Cerner or Epic or whatnot. That will not need FDA approval as well because it's not an AI algorithm. So if your institution downloads it, we're actually making it modular. So if you disagree, for example, or let's say ASH or some other society comes out with slightly different guidelines. So if you disagree with these, you can tweak it. Like I work at North Memorial as well. North Memorial has a 2-tier approach to anticoagulation for COVID. So, North Memorial could, for example, cut out one of these boxes and essentially literally download the same decision support system that we've built. And it's pretty nice in that, when you go in to admit someone or put in vent orders, if they're off protocol or something, it kind of gives you a minor links to evidence and stuff like that. So.
Okay, we have a couple more minutes here. If anyone has any other questions, I see a comment from Dr. Lavallure. She's never been more proud of the U since the start of COVID and what everyone's accomplishing. So those are very high praise, and we thank you for that. And we'll just wait and see if we get 1 or 2 more questions here before the end.
Yeah, thank you very much for saying that. I'm really proud of the U too. It's, when you look at multi-site randomized trials in COVID, who's led more of them than any other institution? I think the U might be the top because University of Minnesota, David Bolt, they've led 2 trials in hydroxychloroquine, 2 losartan trials, and they're about to launch metformin. And these are trials where University of Minnesota was the lead nationally. I don't know how many institutions can say that they led 5 national externally funded COVID RCTs. So very proud of the U.
I think we have another question. Someone's asking, how can alumni support this work and your work, and how can those of us practicing at non-Fairview locations make the best of the data that you're talking about?
One thing that we are really in need of is collaborators for data. So when we build, right now what we're building, give you a hint of our sneak preview of our current project, is to build a prognostic model for COVID. So someone shows up in the ED, what's the probability that they'll die or need a ventilator or dialysis machine or whatnot, and then actually have that update. So that's not super novel. There's already systems out there for COVID, but this one would use X-rays, structured data, comorbidities, et cetera, and NLP data elements, but then also update over the first 5 days of a person's admission as new data rolls in, and that's pretty novel. So we're building that, but one thing that's really helpful is external validation and access to other institutions' data. So if there's any institutions that are interested, the whole pipeline that I showed with us sort of taking Epic data and converting it into a nice, clean database can actually be automated anywhere using our script because Epic stores data very similarly across different institutions. So that's one thing that we'd be interested in. The other thing is we're always looking for additional sites to enroll in studies. So the metformin trial, for example, is launching. More sites that enroll, the quicker we can get results. And if the metformin's a pilot study, so if that shows a benefit, the quicker we can get that out and move to NIH funding and get an even bigger study funded for metformin because it's just a pilot. So I think those are a couple different ways on how alumni can help support us in really taking this data to the next level. Because right now, all we have is internal validation for most of our stuff.
Any final questions for Dr. Tignanelli? We have one that was just submitted. What about the anti-inflammation antibody treatment?
Yeah, gosh, I just forgot the name of the company. Regeneron, I think, has a polyclonal antibody immunomodulator. We're enrolling in that. So we I don't know if we're actively enrolling yet, but we will be. I think we're doing the post-exposure prophylaxis arm. But we haven't, I don't know if we've had anyone in our system get that cocktail yet. But we will soon, and then we'll be able to kind of study it. But Regeneron's preliminary or initial data looked promising. They saw reductions in viral titers. It's the drug that, the cocktail that Trump got. Yeah. The one that's been used for RA. Do you know which one are you referring to? I can tell you if we've looked at that one. We've looked at, again, we've coded up quite a host of medications, and many of the hypothesized medications for COVID we've looked at. Ones that we saw signals in zinc, metformin, ACE inhibitors, ARBs. What else? We saw signals for inhaled beta agonists, inhaled steroids we saw signals on. One of the issues with some of the antibody treatments that we had, like TNF alpha inhibitors and other antibody treatments, is that a lot of patients weren't on them, and we didn't have enough power to really look at anything in a rigorous way. So that might be one issue. The other issue that we had is that let's say that the antibody does work and those patients don't get COVID, then they're not in your database. So for example, we hypothesize that mTOR inhibition is beneficial in COVID. And that's back from that work that we did with the modeling that predicted remdesivir and sigma-1 agonism might be beneficial. The problem is when I pull up our database of all of our COVID patients, not a single patient that was ever on everolimus, an mTOR inhibitor, ever got COVID in our whole system, which was interesting. And I think only one person on Rapamune actually has gotten COVID. So, I mean, potentially the drug's just working, and or potentially those drugs are working and they're just not getting COVID, or just not a lot of people are on it. So that's one of the problems we've had in some of these monoclonal antibodies. But if you tell me the exact name, I can tell you if I've looked at it.
We have another question. Are you concerned at all that as the virus mutates, the data will change?
Yeah, it might. We know last I heard, there's approximately 8 strains of COVID. And there's definitely that one strain that has a mutation in ACE2, I think it was identified in Africa, that replicates significantly quicker. So that would, if the life cycle is going a lot quicker, that would be one thing that we would worry about. We don't have any data currently on what strains we have of the virus, but the thing to note is that we do have samples we have viral samples. We've actually already, for about 100 patients, let's say, we've actually got their viral swabs on them, isolated their viral RNA. Not only have we quantified it, because that was one of the endpoints for the Losartan trial, but we have it all in test tubes at the use, so we could quickly sequence that viral RNA, which we do have approval to do, and then look at, over the course of the last few months in Minnesota, are we seeing the same strain? Are we seeing variations in the strain? And then those could be things that could be added to our model and look at, maybe, I don't know, I'm just gonna make something up, but maybe remdesivir works very well in this earlier strain. And then as we're seeing strain A, we can do a regression on to look at, the strain A respond the same to remdesivir or not. So it's definitely a concern. We haven't looked into it. We actually do have the capability though to answer that question. Obviously it'd be an expensive question to answer, to sequence that. And that's probably one of the biggest issues we have, is a lot of this stuff is expensive. We've been able to get, for the AI, Microsoft was actually able to cover our costs, which is really nice of Microsoft to do, to launch these decision support systems. Epic covered those costs. To do our trials, various foundations gave us close to $6 million to cover the trial costs. But, expecting the school or the hospital to kind of cover it is difficult when, they just shut down 2 hospitals because of financial difficulties. So that Bethesda hospital is actually closing down. There's a press release a week or 2 ago about that. And we're closing down another hospital, St. Joe's. So, funding is probably the hardest thing. We have a huge team, huge data, a lot of interest and questions we can answer. And financial support is probably the biggest thing slowing us down right now, which is to be expected.
Any final questions? We're right at 4 o'clock here, but if there are any final questions.
Oh, you're muted, Maureen.
Thank you, Dr. Tignanelli, for this great presentation. It is really amazing to see the work that the medical school and other parts of the university have been doing on COVID-19 research. This is really excellent. And